Hey, everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways.
So we probably talked about this in a past episode already, but I think that this would be a good segue into the... We know that this is last ditch, but what patient is a candidate for this?
Great question. So all patients are candidates per University Hospital's protocol. 12 and over are candidates for this. Depending upon where you work at and what you read, research has said between 8 and 10 is okay to do cricothyrotomy on. And the reason for that is because as we are developing, your throat's also developing. These structures that we're going through are developing. We don't want to damage those structures, the development of the throat, the airway, that could cause longer-term issues down the road. So that's why we have the cutoff for age. Research says 8 to 10. University Hospital says 12, which aligns very nicely with the size of the quick trach that we'll talk about. But if it's underneath that, if you're under 12 for university hospitals, you can do what's officially known as jet insufflation or needle cricothyrotomy, which also understand is not really specifically ventilation. It's oxygenation.
You're buying some time.
Yes.
Yep. That's exactly what it.
And we just wrapped up 2 more RSI classes with one of the docs, and that was a huge point that we have to make when we talk about using even like the Roche Quick Trach, is that this is for passive oxygenation only, not ventilation.
It's buying you some time.
And it's buying us time that we need to be sure that we're getting the patient to a good hospital at that point who's going to replace that airway and be ready for it. So call ahead. Hey, I've used this. We're passively oxygenating this patient, and we are going to need an airway when we get there.
Yep. And we'll talk about sizes, but with the quick trach, at least that's inner diameter of 4. You can move an okay amount of air with a 4. But
minimal ventilation.
You're getting minimal ventilation for that.
For adults,
yeah. But for the jet insufflation, because you're using
very, very
14 gauge needles, you're just providing oxygenation.
Yeah. So I have a 14 gauge here, and to do a needle cricothyrotomy, you actually want the shortest 14. So, and I've got that just so nobody confuses here. We got our typical chest dart here, right? At 14, 3 1/4 we would use for decompression, and we need that length and get to the pleural space, get to the pleural cavity to decompress a chest. This is not the one you want to grab in your. So I mean, you might have this in your airway kit, right? But this is not the one you want to grab to do any type of neck access.
I mean, the chances are I'm going to go right through the trachea into the esophagus.
So
this is a reason why you're inserting the Roche or any of these. You should be withdrawing to get air aspiration as you've made it into the trachea.
So I know at my previous shop when we set the airway kits up, so those were in our airway kit, and then we also took the shortest 14 we could find, which in our house was a 14 2-inch, and wrote on them cric needle, right?
Yeah.
And we would take that, and then the pieces here we're going to talk about in just a second. We kind of kitted those together, so you had everything together, and you knew when you were in the moment. I didn't have to reach into my IV cabinet to get an IV catheter and have to shuffle through and figure out which one. And again, I'm kind of approaching this from the adult perspective, so the biggest needle. I've got an 18 here, right? If I had a small kid and that was the biggest thing I was going to get in their neck, then 18 it is. But to Dr. Hill's point, this is this is just going to provide some minimal oxygenation, and we can get more in. Fluid dynamics apply here, same as running IV fluids, right? The shorter and the wider, the better we're going to get, the more flow we're going to get in.
But understand, and you're probably going to get there, but you are limited to this anyways.
Correct. Right.
So when you're pulling your ET tubes, and this is part of what he'll talk about using, you're limited to this diameter anyway.
Absolutely.
So you're not getting much worse.
So we just need something then, of course, to adapt this to a BVM. There are such things. You've kind of set the stage up to talk about, called TTJs or transtracheal jet ventilators. I've never had one in my practice. I know our critical care service used to have them on the trucks. I've never used one, but it goes to your high pressure source on your I guess the field workaround has been, of course, to adaptive BVM. Depending on the manufacturer, and I was just looking as which size this was in my flashlight a minute ago. This is a 3.0 ET tube airway adapter.
That's what I was going to say. Typically, 3 to 5 endotracheal tubes should fit directly onto your angiocaths.
Yep. So we ripped this off. I have found some brands 2.5s fit better, and some brands 3, and this just happens to be a 3. My commentary here is this should not be something you're trying to put together in the moment, right? So we had purchased a box of, and I don't remember if we had 2.5s or 3.0s, whatever of the brand we were buying at the time, probably Sun Meds or something. We figure out what worked. We bought a whole box of them, and then we ripped all these off and then put these together in our airway kit. So in the moment, you weren't looking for this, or because you're going to go through the entire thing. Patient's going to expire in the meantime.
And I think that's a great point, that your airway kit should be, if you're permitted to do cricothyrotomy, whatever what that is, all that stuff should be in your airway kit.
Yep,
just
absolutely.
already there. You shouldn't be digging through. If all you have is going to be a bougie, a scalpel, and a 6.0 ET tube, you shouldn't have those 3 things in different places.
Different places,
They should
right.
all be in the same spot.
And us being an RSI department, we have a ALS bag that has LG in it and VG, and then we also have a separate bag that has everything duplicate with the cric kits in them.
Yeah.
So, I mean, everything's there. It's in one bag, and you pull it out, and it's not the same as the CPR or ALS bag.
You should be able to force escalate from OPA through knife in that
And that's exactly what's there.
one kit roll, however you want to deploy it. That's
And it starts with eye gels, and it moves all the way through.
yeah, right. So, and then let's see if I can do this one-handed, all feel over the top here. But yeah, you're just going to appreciate the cricothyroid membrane. Again, all of these trainers have gigantic necks.
Yes.
It's far easier for us to demonstrate. Understand you're probably going to take a little more time, and you might actually.
I tell people to start with that Adam's apple,
Yep.
that prominence
Yep.
on, and you
Yep.
just come down. You're going to feel a dip, and you're going to feel a soft spot on yourself. It's going to feel a little uncomfortable when you press on it.
Yeah.
And so you're going to feel that dip. You're going to feel a hard ring underneath, but that you're going to go right above that.
Over the
And
heart. Yep.
If you're going to fail, you want to fail low. So we call this cricothyrotomy because you're going through the cricothyroid membrane. But if you do fail and you go underneath, that's just a tracheostomy. That's the only difference. It's called a different thing because it's going into a different space.
Yep. And actually, I mean, this is good. I actually met a little bit of resistance there. I repositioned, got that where I wanted it, and now we can connect our BVM straight to that. And just, again, back to Dr. Hill's point, I'm going to squeeze this as hard as I can, and you can see that this thing just barely deflates.
And that's a good bag, too, that
We're going to
Palmidine.
It took you long enough.
I was waiting for it.
We got that. I mean, arguably the harder part here is you're going to have to, your inspiratory to expiratory ratio is going to have to be a little bit longer to let some of that air come out. Maybe even consider disconnecting this briefly to let some of that CO2 out. But again, you still 100% oxygen. You're going to tape this down, duct tape this, super glue, hot glue, staple gun, whatever you've got that works. I mean, there's no kind of right or wrong way. This is an ad hoc thing to begin with.
And remember, this is passive
And
oxygenation.
yep, you're buying time.
That if you do see up here, first of all, you probably didn't need this. You probably could have intubated. And second of all, you're still passively oxygenating. It's
Correct.
not going to do you too much justice for ventilation, though.
So.
And I think you got to set your equipment up for success. I agree with you. A lot of people overlook that standpoint of anything where you're going to have to pair multiple things together. You need to make your own kit and have it ready to go. This is not something you want to be fumbling for, trying to obtain it all, and then, piece a 2.5 or does a 3 fit, and then it goes south from there. So you really need to set yourself up for success if this is the effort that you're going to do when you're doing this needle cric.
Why would I do this? So we talked about last-ditch effort, but why? What is happening up here that I need to do this?
So you would essentially, everything else has failed, whether there's some type of trauma where you're not able to identify any structures to ventilate your patient with, let's go like simple to complex, which Scott already kind of did in the beginning, is I have an oral airway and a BVM, it does not work. I cannot ventilate my patient with a iGel airway, it does not work. I cannot identify structures. Maybe let's use a gunshot wound to the jaw, because actually I think we were talking about a case where I was talking to Dr. Garlisi about a case with oral trauma. It was a self-inflicted GSW, and then the patient lost their whole lower jaw. And it was just, they were not able to access the airway that way. Then I needed to move to that because they're not moving in the air on their own. We have to address it. So essentially, if anything that you're going to do, BVM, iGel, King Airway, intubation, video, if it's not going to work, this is the absolute last resort, because we have to, whether you're oxygenating them or we're going to try to ventilate them, depending on which one of these you're going to utilize. Needle is probably more prominent in our protocol with peds. That's probably where we see that the most. I think this is what's coming up. This is what we use in our organization. The most is the Roush Quick Trach. Yeah. But I always have looked at this as like it is your absolute last ditch effort. You tried everything else and it failed. Dr. Singer says that all the time. So do you, whether it's due to oral trauma, tumors, something maybe it was some type of tracheal injury, upper tracheal injury.
Lugwin's angina. I mean, there are cases of complete occlusions that, you can't get around. And I think that I like to reinforce the fact that this is truly last ditch, and here are some of those reasons why it might be last ditch.
Yeah.
I mean, if I have a patient who I've missed 4 or 5 attempts, other people have tried at this point, we can't intubate them, they're crashing, but I can still oxygenate with a BVM, that's my best thing to do.
That's fine. You
That's,
do that, right.
Don't go any further.
I think one of the other misconceptions, to try to add to your point too, is we talk about all I'm going to go BLS to ALS, right, with BVM,
right,
iGel, and then intubation.
Go backwards sometimes.
Go backwards. I think that's a huge thing. So if you were able to ventilate someone with a BVM and it worked, and for whatever reason your iGel did not work, and for whatever reason you're unable to intubate them, but if you can oxygenate your patient and ventilate your patient with the BVM, it doesn't mean I have to crike them. It means I could go back in reverse and go back to a BLS skill.
I sub-taught the basic class yesterday, and it's not a class I get an option to usually do. And during that, I made it very well hard hit to them that you're the ones that are going to pull the paramedics back and say, hey, let's start with airway again, and maybe a BVM and, a nasal trumpet and an, oral pharyngeal is all you really needed.
Yeah.
But I'm like, that's
BVM and oral pharyngeal airway go a very long way.
They do go a long way, but by the same, you guys are talking about if the BVM works. If the BVM works, then you would never escalate to this anyway, right?
Correct.
Because
and that doesn't make you a bad medic.
It does not. But because you haven't met the unable to intubate, unable to ventilate criteria.
Correct.
There is a technique. It's just not the coolest technique. It's just not the most
correct
isolation of the trachea. But it's still a 100% viable option. OPA, NPA, just like
now, none of you guys have done a crike. I've had the unfortunate pleasure of doing a crike. My patient was angioedema. And
allergic or ACE inhibitor?
ACE inhibitor. Hereditary.
Yep.
Okay.
And that's crazy too. Not to sidetrack too much, but ACE inhibitors at any time they can get it. It doesn't have to be
correct.
Yeah, and that's typically who we do our crikes on. We've had 2 in the last few years that have done angioedema for that reason.
Both lisinopril.
Yep.
That is the most of all the prils,
but it's the most commonly prescribed, right?
Just so happens to be the one I'm on.
You've got high blood pressure first line. Lisinopril
is a pro.
Yeah.
Hop up on this table. We'll cut your neck.
We might do this live.
Yes. We'll even overlook the angioedema.
But my guy was for him, I was in there every few minutes just to check on him. Hey, I will take care of you. We'll give you some medications. We're just going to watch you. I need to know if this gets worse. I'm going to come in and every few minutes I'm going, hey, are we doing better? Are we doing worse? Are we saying the same?
Better, we're saying.
I'm fine. Until the last time I went in there, I go, how are you feeling? Better, worse, same. He opens his mouth and all of the saliva falls out of his mouth. That's like, you son of a bitch. Like if you would have told me beforehand it's getting worse, great. I can sedate you. I will put you down in a very controlled environment. You're not going to remember any of this. You're going to wake up on the other side and you're going to feel fine.
Yeah.
Not, holy shit.
Now I got to go.
I got
cut. Right.
So, and we were able to bag him for a very long time. We tried a lot of things on him, and ultimately we failed to a cricothyrotomy. Single-handedly the most terrifying moment of my professional career to do a cric on a patient. I've had one as a very early in my career, so if we're doing averages, I'm probably going to have another one in my career. But it's something you guys need to be practicing and be useful, and hopefully I don't ever have to do one again.
Right.
But statistically, I'm probably set to do
Right,
too.
right. Well, just with the volume of patients you see, it's,
Correct.
yeah, it's a statistic probability, like you said.
Yeah, and I guess that helps further the point that, I mean, the volume of patients that you've seen, and you've done one in your career, and you've been
Yeah,
an MD
yeah.
how long now?
I'm on my 7th year.
Right.
Yeah.
I mean, that shows, I mean, how rare this should be.